Good morning, everybody. Thank you very much, Dolores, for such a kind introduction. And I'm going to concentrate on the presets for color Doppler and a little bit on 3D technologies, and also review a new technologies which are just getting to our clinical practice. And I believe that they will help us to revolutionize the first trimester cardiac imaging and help us to see even more details in the heart and the other vascular structures of the fetus and the placenta. So I have two disclosures. I participate in educational events for GE Healthcare, and we have a big NIH grant for assessment of the placental development during pregnancy. And just to summarize the beautiful two talks that were prior to this one, so technically approach to the early cardiac imaging can be divided to the screening approach and to the more detailed approach, which is the fetal echocardiogram. And this is very similar to what we usually do in the second trimester. And here you can see the specification of these exams. And in my talk, I'm going to concentrate on more advanced evaluation of the fetal heart in first trimester. So here you can see that fetal echocardiogram, this is indication-driven exam. And here you can see the most common indications when we recommend the early assessment of the fetal heart or fetal echocardiogram, or our referral physicians can send the patient to us for that exam. And as you can see here, they were mentioned before, this is increased nuchal translucency or cystic hygroma, abnormal blood flow in the ductus venosus, presence of the mitral or tricuspid regurg, abnormality of the four-chamber view, including the abnormal cardiac axis, and also some maternal complications such as the poorly controlled diabetes, morbid obesity, and maternal anxiety related to the previous pregnancy that was complicated by cardiac abnormality on the fetus. So for early fetal echocardiography, we can apply the guideline or clinical parameter that was published by AIOM. And usually we try to achieve visualization of these 8 views in the early gestation in 2D and color Doppler, and this is what's required for the second trimester, and this is what we are trying to achieve in the first trimester. So then you pronounce color Doppler in the first trimester imaging, then especially if you're giving presentations in the United States, that raises a lot of anxiety. So this is kind of, people feel very uncomfortable, but I believe that any tool that you can have for diagnosis, if it's used appropriately, if it's used according to the existing guideline and recommendation, it's safe and it actually serves the patients very well. So, and as you can see here, several years ago, there were several guidelines proposed for the proper and safe use of color Doppler and spectral Doppler in the first trimester. And here is the ESOG guideline that you can find on the official ESOG website. And you can see that the color Doppler and spectral Doppler in general should not be used routinely, but that can be a very important part of the detailed assessment, like fetal echocardiogram. So the ESOG guideline recommends that you keep your terminal index below 1, or even equal, and overall you can expose the baby to Doppler to 5 to 10 minutes, and usually it's appropriate and achievable, so you just turn color for a few seconds and you already can acquire a very good clip that shows you a lot of details. And overall exposure shouldn't be more than 1 hour, which is hard to believe that we will be able to scan the patient for such a long. So in comparison, the guideline from the AIOM is a little bit strict, and the main difference is that the AIOM recommends to keep the terminal index below or equal to 0.7, and if you're going through accreditation process, so this is an important thing to keep in mind and make sure that all the images that you're submitting comply with this. So We use our tool safely, and then we need to make sure that we get the most out of this tool. And before you turn color on, I think that it's extremely important to make your 2D image perfect. So you need to optimize your 2D image first before you even try to turn color on. And here you can see the steps for adjustment of your image. And as you can see, the first five bullets here, this is how we adjust the 2D picture. So again, our goal to have a very good temporal resolution and have a compromise between the size of the image and magnification and the axial resolution, so the picture, as Lisa pointed out, shouldn't be very pixely. And then you turn the color on. So new machines, they have already the preset for you, which is labeled as the first trimester heart, or in T usually has a very robust preset for the early cardiac evaluation, that color. But what's important if your preset doesn't really work very well for you, so make the adjustment that you would do in the second trimester for visualization of the pulmonary vein. So what do? You would decrease the color wall filter and you will decrease the pulse repetition frequency, so just to make the smaller vessels visible, because the intracardiac velocities are relatively low in the first trimester, so this significantly improves your visualization. And then you need to increase the color persistence, and please adjust color gain and color Doppler balance, because it also helps you to get the ideal picture. And of course, for any Doppler technique, we want to maintain the parallel orientation of the ultrasound beam to the structure that we're interested in. Okay, so now we are fully equipped. So we use our Doppler properly, and here you can see how well you can identify the intracardiac flows if you use Doppler in the first trimester. So we can see the two separate inflow and even the outflow here on the right side. So this is the perfectly normal heart. So the resolution in the 2D is appropriate, the magnification is appropriate, and the color used appropriately here. So it's more and more evidence in the literature that using the protocol that includes 4-chamber view and the free vessel and trachea view in combination with color Doppler helps us not just detect but also diagnose in details cardiac anomalies between 11 and 13 weeks gestation. And I believe that this is the future. And again, the appropriate optimization of the imaging, it can be achieved on every pregnancy that we scan at that gestational age. So as was highlighted, so if we are trying to do screening, use of color or a power Doppler may help to enhance the measurement of the cardiac axis and can help highlight the interventricular septum for us, that then eases the placement of the lines that are applied for measurement of the cardiac axis. So then we were doing cardiac axis, and then we apply color. It helps us to highlight specific features of the 4-chamber view, sometimes even if the cardiac axis appears normal, as in this case, but that allows us to see discrepancy in the left and right side of the heart, and that could have a very significant diagnostic value for early diagnosis of different congenital heart anomalies. So tricuspid insufficiency, and here is an example how you can visualize tricuspid insufficiency using color Doppler and spectral Doppler. We usually see tricuspid insufficiency on color first and then try to apply spectral Doppler just to confirm that it's not an artifact and this is a true and is regurgitation. And as you can see in this case, this is the holosystolic regurgitation that Ellie is saying so meets the criteria for the true regurgitation. So sometimes you don't really need to use color, because just by looking at this panel that demonstrates the 2D image, you can see that the right side of the heart is significantly enlarged, and in particular the right atrium is enlarged, and you already can expect presence of significant tricuspid regurg, and then we turned the color on so you can see tons of that. And also, if you look at the overall appearance of this view, we can see significant skin edema. So baby was hydropic and had a significant tricuspid dysplasia and was diagnosed also with Down syndrome. And this pregnancy resulted in demise in 2 weeks after the scan was performed. But sometimes things are not that easy, and here we can see the 4-chamber view, and if we look without color or we don't use that, so we may say, okay, a little bit of the pericardial effusion, pretty common finding, especially if you scan the fetus between 11 and 12 weeks gestation, and all the chambers are symmetric, and it seems that it's kind of nothing to worry about. And even if sometimes it looks like it might be a linear insertion of the V leaflets, most of the time then it looks like that, and it's an artifact in the first trimester, especially if the heart is in the apical position. So, but we used color, and color highlighted very interesting finding for us that we truly were not expected to see. If you can look at this color Doppler, you can see that the mitral valve shows significant degree of the mitral insufficiency, a little bit on the tricuspid valve as well, and that's supposed to raise the red flag for you, and this fetus should be evaluated early. And we also applied spectrodoppler. It was early systolic mitral regurgitation, and then fetus and this patient underwent the formal fetal echocardiogram late in pregnancy, and you can see that that was the case of complete EV canal with relatively small ASD and VSD, so that this is something that you cannot detect or can miss in the first trimester. Karyotype was normal, but this fetus, this mother had a really poorly controlled diabetes. You can see how thickened the right ventricular wall is. There is still persistence of the pericardial effusion, and that's why this is very important to evaluate this category of patients. And so use of color Doppler definitely helped us to make this diagnosis and suspect it in early gestation. Another important thing that you can discover with color, so where the regurgitation on the AV valve is positioned. And as you can see on this clip, the regurg sits right in the middle where the crux of the heart is supposed to be. And this is very typical for patients with AV canal or problems with the development of the crux of the heart. And if you see that not on the right side or the left side, but right in the middle, so that is really very sensitive feature of AV canal in early gestation. So how about septal defects? Of course, isolated VSTs, they are outside the scope of the early imaging, but sometimes you can see this, and this fetus had complex congenital heart anomaly, and as you can see, color helps to highlight the big inlet VSD. It also extended to the outlet, and here we have the same fetus on the left. This is 13 weeks gestation, and on the right this is 17 weeks gestation. So baby has mid-mascular VSD, and sometimes with appropriate use of color you can see even this very not much clinical significant findings, but sometimes you can see even that. So how about the great vessels? And here we have the case that we had last year, and this is the sagittal view demonstrating on the 2D that there is a vessel that overrides the septum, that this vessel has the teeny one that arises from the side right above the valve. And if you look at the color Doppler allows us to highlight that we have the other vessel that originates from the arch, and that was the case of the common arterial trunk. There's the origin of the pulmonary arteries on the different level, and use of color Doppler helps us to see that as early as 13 weeks and 6 days, like in this case. All right, So what else we can see? We can evaluate the vessels and the branching of the vessels. And here is the very good example of the aberrant right subclavian artery on the fetus at 13 weeks gestation. As you know, the aberrant right subclavian artery is the marker for the chromosomal problems, including Down syndrome, and it's also very common in fetuses with DiGeorge. And we were looking very carefully in this case because mom had DiGeorge and had the deletion 22q. And we even looked at the size of the thymus, and here you can see how you can evaluate the thymus using the box technique. Then the tissue of the thymus is located between the internal thoracic arteries, and on the back we can see the brachiocephalic vein, and you can see that in this case that the aberrant right subclavian, the thymus was very tiny, and this is the normal 3-vessel view showing the significant distance from the appearance of the aorta to the sternum here that highlights the normal size of the thymus. So as early as 13 weeks gestation, if you use your color appropriately, you can evaluate not just the bigger vessels, but relatively tiny vessels and the thymus, especially when it's indicated. As was mentioned before in the previous talk, evaluation of the pulmonary veins is very challenging, in particular up to 14-15 weeks gestation. And here we can see the case of univentricular heart tricuspid atresia, but color Doppler allows us to see pulmonary veins pretty good. And in this case, we use not just color Doppler, we use the power Doppler that also allows us to see the direction of the blood flow. And this introduction of this technique, our ability to see pulmonary veins were significantly improved. But the newer development in the technology that we can see pretty much in every manufacturer in the past year, so that we can improve the ability to see the smaller vessels even better. And in different companies, this technique called differently. It's SMI or slow flow. But as you can see at this diagram, so this is what we were able to see before, the just power Doppler, and this is what we can see now, the very good resolution and without bleeding artifacts. And this is what the images look like. So this is the sagittal and transverse view showing us the vessels of the liver here. And look at the, this is the fetus at 12 weeks and 6 days using trans-abdominal high-frequency probe. And you can see that here we have a picture which is not different from the second trimester ultrasound. And again, here we can evaluate on the sagittal view the aortic arch and relationship of the main veins returning back to the right atrium. So this is the future, and I'm very much impressed at where the technology can take us. So another example, here we have a clip, and this is how well we can visualize the pulmonary veins, and this is the transvaginal approach. And also, because on the clip, baby at this gestational age usually moves a lot, so we can see that here we can scroll and use the cine-loop mode and look through the clip and retrieve the frame that allows us to evaluate the situs and relationship of the IVC and aorta at that level, see the portal sinus here. And then we can retrieve the 4-chamber view, evaluate the pulmonary veins, evaluate the position of the descending aorta, interventricular septum, and also this technique allows us to put the spectrodoppler cursor appropriately and detect the normal blood flow in the pulmonary veins. And all this can be done very quickly, and the resolution of these images is pretty amazing. I think that in the next couple years, our ability to see the tiny vessels and diagnose the complex malformation like the total anomalous pulmonary venous return, for example, would improve substantially. So as I mentioned, that there is a lot of evidence in the literature that in many cardiac abnormalities, there is also abnormal development of the placenta, and this is what we are doing as a research. So, and you can see that the new technology is allowing to highlight the blood flow in the vessels of the placenta starting at 13 weeks gestation, and this is how well we can see the vasculature of the placenta, and we can evaluate that, and I think that there is a lot of potential for research, in particular to show that the patients with the abnormal cardiac development also have abnormality of the development of the placenta, and we can make these measurements quantitative, and this is what we are doing for the last 4 years, and I hope a lot of data will come out of this, and we can evaluate using the spectral Doppler the blood flow in the spiral arteries and the fetal arteries, and can see the dynamics of change of the characteristics of that blood flow that could be very diagnostic and can help us to predict the complications of the pregnancy and the adaptation of the fetal cardiovascular system to them. So another example, and this is our recent case, and we can see here that the heart is definitely abnormal. We can see that this color highlights just single inflow, so it's like EV valve, just a common valve or atresia of the valve. It was hard to tell. It was transvaginal ultrasound, but then we looked at the pattern of the blood flow in the pulmonary veins, and we didn't really like that. So then we turned the probe and got the sagittal view, and you can see here, unfortunately I can't point, but if you look at the image of the inferior vena cava, you can see that from the top there is a red jet of the blood flow that indicates the collector vein that connects to the inferior vena cava, and this spectral Doppler is obtained at that point, and this is the, our earliest diagnosis of intracardiac total anomalous pulmonary venous return on this fetus, which was confirmed late in pregnancy. So there were several cases of the left heterotaxis syndrome that associates the second degree or complete heart block, and here is our observation. And it was very interesting that the abnormal heart rate was detected on this fetus starting at 9 weeks gestation, but it was reported 140 and then 90, and back and forth, what was very confusing. And this is because it depends where you actually obtain your heart rate and where your M mode is dropped through what chamber. So because here we can see the arterial, the atrial, and the rate of the atrial rate is 144, but the ventricular rate is 69. So this indicates that it's very important if you're suspecting the abnormality of the heart rate that early. Usually this situation has a very poor prognosis, so that you make sure that you're evaluating the atrial rate and ventricular rate, and that you're applying M mode appropriately. And as you know, AARM recommends to evaluate the heart rate at any gestational age, starting from the M mode. If your M mode doesn't really work very well for you, so and this is another case that we actually have going. So you can see that this heart is, it's a mesocardia, there is the common valve, and the myocardium is very thickened, and the heart rate here, the ventricular rate is 77, and the atrial rate was 169. We also use the tissue Doppler here, and you can see very clearly that this is the atrial rate at the bottom, and this is the ventricular contractions, and they are twice less frequent than the atrial contractions. So this fetus now is 18 weeks gestation, hydropic, and has evidence of the myocardial non-compaction. So altogether that associates with a really poor outcome. So what are the other tricks? We have 5 minutes left, and so we discussed briefly that the transvaginal ultrasound gives us a lot of advantage in the imaging, and we use that all the time in our approach to the detailed assessment of the heart. Always try both transabdominal and transvaginal, and this is just to highlight how different the image could be. So transabdominal, definitely not the optimal view. You can see a lot of speckles, and the image is not crisp, and the transvaginal allows us to visualize a lot of details within this heart. So, but when it's really important, and I think that everybody had this situation that is presented here, that, you know, obesity is the main problem of non-visualization in the United States, and sometimes, as you can see here, it takes the team effort to get through the scan. As you know, those patients usually have very poorly controlled diabetes, they have obesity, they have a lot of complications of the pregnancy, and this is exactly the person where you want to see as many details as you can, and this is usually where you start from. Then you hardly see that there is a baby in the uterus. So, and this is where the transvaginal ultrasound can actually make a significant difference for you. And we performed the prospective study. Then we evaluated the fetal anatomy assessed by transvaginal ultrasound in late first trimester, second trimester. And this is just the example retrieved from that study that was published in JAMA in 2018. That this is the second trimester ultrasound transabdominal, about 20 weeks. This is the morph age. Yeah, can you see the heart here? Nah, maybe that's something very, you know, blurry in this spot. But this is the on the other side, we can see the transvaginal ultrasound obtained on this patient, and her BMI was 47.7. So this is increased. So our highest that we had in the clinic, it was 98. So this is really the problem, especially in our area. And we changed the practice. So now every single patient who has BMI over 40 at the presentation, at the first prenatal visit, so they are offered to take a look using transvaginal ultrasound between 14 and 16 weeks for the early morphologic evaluation, including the screening for congenital heart anomalies. And I believe that this is really a good approach. And this is another patient from the study and highlights the use of color Doppler. So BMI of 43 almost. And here you can see the perfect heart, pulmonary veins, and all the chambers. And so here you can make sure that of course, the evaluation of the outflow tracts, that you're not missing a major heart anomaly. So how about 3D and STIC in early gestation? You can see that several studies were published, and it was found that the STIC acquisition and interpretation of the cardiac views between 12 and 14 weeks gestation is feasible. It's also possible to interpret the images and send the images for the second opinion to the expert, and that overall this technique definitely can help if you deal with the very complex cardiac anomalies. So here is just the standardization of the acquisition. So similar to the second trimester, you need to apply the box right outside the borders of the fetal chest. We prefer to acquire all the volumes at the level of the 4-chamber view. We keep the acquisition angle in between 15 and 25 degrees. And this is usually the steps that you have to take just to optimize 2D, then to apply appropriate presets for the volume acquisition, then you acquire volume, and as soon as you get the volume with appropriate quality, so then the manipulation of the volume and the volume display limited only by your imagination and time that you have on the machine. And this is usually how the volume comes out, then the acquisition is completed. This is the planar imaging, and you can go to the little bit manipulation. Then we prefer to set the spine at 6 o'clock and the apex pointing to the left side. And here on the plane A, we can see our reference plane, the 4-chamber view, and then we clearly can see on plane B, this is the beautiful ductal arch, and that is very helpful. So also you can use the tomographic imaging display, that again, the same fashion that we do in the second trimester. And finally, you can use the rendering mode, and you can choose and pick any color, highlighting of the surface of the heart, or inversion mode. So again, there are lots of options. If you push every single button in the machine, I'm sure if your volume acquisition is correct, if the volume is of the good quality, so this is what you can get, and this is pretty amazing pictures. And particularly if you look here, there is a moderator band in the right ventricle, but there is also a linear structure that only the 3D can highlight for us, which is the false tendon. And sometimes these babies after birth have a systolic heart murmur, and you can see as early as 13 weeks gestation that most likely this is going to happen after birth. Pretty amazing. Right? But it works even better when you deal with the major congenital heart anomalies. So here we have the, definitely if you look at the top pictures, we can see that the heart is pointing to one direction and the stomach is on the other side. And on the bottom, we can see that there is the definitely right-sided aortic arch, and there is just one big vessel. All right, so let's move on. So also we can use the 3D rendering together with color. And we can see the blood flow here, and in the 4-chamber view, in the free vessel and trachea view. And again, this little tiny red jets indicate for us where the internal thoracic arteries are. We can choose the monochrome map, and that allows us to highlight the interventricular septum. And here we can confirm that there is no major defects in the interventricular septum. So here we can see the 4-chamber view in 3D rendering mode with color of the normal heart, and EV canal with some regurgitation on the common valve. Again, very easy to interpret, and based on our experience, it's much easier to explain the patient what's going on if you have these images side by side for the counseling. So another example, this is the case of tricuspid atresia. You can see that we have 2 atria, normal drainage of the pulmonary vein, big left ventricle, and the area where you expect to see the right ventricle is actually absent, so it seems like it's missing completely. And also, if you look behind the left atrium, we can see 2 vessels of the same size. One of them is the aorta, and another one is the inferior vena cava. That indicates the interrupted IVC, that azygous continuation. And all this you can retrieve from just one good volume, and then your interpretation is much easier. So the opposite situation, so here we have the left side of the heart underdeveloped, and this is consistent with the hypoplastic left heart syndrome. And again, this is very easy to interpret and explain to during the counseling session. But we can also go beyond the cardiac structures. 3D, and this is the 3D static, is very helpful for evaluation of the vasculature. And here we have very common malformation consistent with the persistent right umbilical vein, and as early as 13 weeks gestation. And the next slide shows just a confirmation of the same case in the second trimester here. And on this side, we can see the normal vasculature of the abdomen. And usually these patients are referred, this is a suspected heterotaxis syndrome. As you can see, in case of the persistent right umbilical vein, the gallbladder tend to be on the midline, and this is usually something that looks very suspicious for heterotaxy, but it's not, it's just persistent right umbilical vein. So, and I would like to thank you very much for your attention. So, but I believe that now you will feel more comfortable and not afraid to use color for the early cardiac imaging. Thank you very much.